Hello, my name is Charles James. I'm the Executive Director of the Rural Advantage Accountable Care Organization. Most of you know me as the President and CEO of North American Healthcare Management Services. We've been providing technical support and assistance to rural providers across the country for 32 years. Now we have established the Rural Advantage to help guide our participants into the world of value-based care. Our mission is simple: provider and patient well-being. We put providers first on the premise that our providers are suffering, and any help, any assistance we can give them to relieve that pressure helps them, helps our providers, helps you treat patients better. So our mission is simple: provider and patient well-being. As I mentioned, you know me as the President and CEO of North American. I've provided technical support across the country to rural health clinics as President of North American, and our company provides all levels of support to rural health clinics: billing, cost reporting, and we have deep experience in all the technical aspects of making sure you can succeed in value-based care. Our medical director is Dr. Kelsey Hopkins. He comes to us from Greenville, Illinois. He's a North American client, and he is also a Rural Advantage. Greenville Family Medicine is a Rural Advantage participant, and Dr. Hopkins is helping us engage with our providers and help think of new ways that we can change our practice, that we can start directing our practice and orienting more towards value-based care. Our technical expertise for value-based care comes from Pinnacle Healthcare. Kelly Conroy leads that team. Kelly and her team were instrumental and helped found Aledade back in the day. So Kelly and her team has provided us enormous knowledge and wisdom of helping us make the transition to value-based care. The ACO provides you information about your Medicare patients that CMS has. ACO patient attribution is based on just that, patient attribution. It is not based on your provider visits necessarily. It's based on an algorithm that CMS uses to assign patients to providers. We consolidate and coordinate and provide that CMS information back to you so that we can provide benchmark and historical spending trend analyses. We also determine the measures, the quality metrics that we're going to follow for the year, and we help assess documentation, because this whole exercise is based on providing the service and, of course, just like we've always known, making sure we document it correctly. The Rural Advantage, there is no cost to get in, there's no downside risk, and there's no long-term contract. We're fully at risk. If you come on with us for a year and you're not happy, you can get out. Most other ACOs have a 5-year contract. We do not. There's no cost to you. This does not reconcile like an RHC cost report. And Medicare shared savings revenue is in addition to, on top of, parallel to, separate from RHC claims and cost reporting. There's no impact on your claims, positive or negative. The payment comes later. We help make sure that your claim flow is correct so that the appropriate information gets to Medicare. And part of the whole bet we've made in this is that most of us are not billing preventive services correctly. And this does not affect participation with Medicare Advantage or other value-based products that you might have with Medicare Advantage. But if you're already in a Medicare ACO, then it's one or the other. But it does not affect participation in Medicare Advantage. But all of these measures are extremely important to Medicare Advantage and can be financially beneficial to you for all payers. But when you join, you see no impact on claims anywhere. We're track A. No risk, no shared loss. The savings rate is lower, but this is really entry level on how we get into value-based care. Our payments are over and above claims revenue. As I mentioned, there's no impact on claims. Here's our scorecard. Maintaining patient attribution. How are you doing with annual wellness visits? Do you participate in education and learning? Are your providers engaged? And what does your facility utilization look like? Inpatient, ER, SNF, outpatient, and then physician services. This is how we score our participants and ultimately distribute funds. Here's an example of some of the information that we pass on. We talk about risk scores. A lot of problems talking about risk scores lately, but we're promoting accuracy of risk scores. It's important that our patients are diagnosed accurately. Here's another version of our scorecard. Attendance at our educational sessions, panel size, annual wellness visits. We want to achieve greater than 70% of patients eligible for annual wellness visits get one. And of course, we're going to track these other utilization trends, and transitional care management is 20% of our score. We never come in and ask you or tell you how to treat patients. We never interfere with that relationship. We're here to provide you tools. Our revenue split is 75-25. Providers keep 75, we keep 25%, and that is net, but our commitment is to keep as close to 25% as we can, and our expenses are lower. Here's the trick. We're going to come in and talk to you about how to properly report CPT cheat codes for all payers. Medicare shared savings is practice. Practice. All payers have lucrative incentives right now. These apply to all payers. That's what we're here to talk about, really. Nationwide enrollment deadline is August 1. August 1. All ACOs must enroll new participants by August 1. Like I said, there's no immediate change on your remits or anything else. You sign the participation agreement, we add your EIN to the portal, and we start with a risk assessment and start assessing what your practice looks like already. Then we go through program year 2025. The payment is received by the ACO in September of 2026. Please contact me. We'd love to have you as participants. Come join us. Come be with us, the people that know rural health clinics like no other. Thank you for listening today. Appreciate your time.